Hi, everyone. It's great to be here today. First, I'd like to start by just going over a little bit of introductory material regarding small fiber neuropathy. So to back up, in terms of peripheral nerve fibers in general, there are two categories. It's important to remember. There are large diameter and small diameter nerve fibers. And what we're discussing here is a neuropathy that only involves the small diameter nerve fibers. Usually when we think about neuropathy in general, we're thinking about neuropathies that involve the large diameter nerve fibers. These are myelinated nerve fibers that involve, that subserve both sensory and motor function. So neuropathies in those categories of nerves can cause sensory abnormalities as well as potentially weakness. The small diameter nerve fibers are either unmyelinated or thinly myelinated and are only responsible for sensory modalities only. These nerve fibers are located in the superficial layer of the skin, known as the epidermis, as well as in the sweat glands of the skin. And also these nerves are involved in innervation of the cardiovascular, genitourinary, and gastrointestinal systems. So again, as I previously mentioned, the small fiber neuropathy is a type of neuropathy where only these small diameter nerve fibers are affected. A recent study looked at the prevalence of small fiber neuropathy in the southern Netherlands and found that this was approximately 53 cases per 100,000 people in the study. The incidence happened to be higher in men than in women, and the incidence was also higher in older individuals. So as I mentioned before, the small diameter nerve fibers in the skin only subserve sensory information. No motor involvement is found in the small fiber neuropathy. So the sensory symptoms can include pain, numbness, or other uncomfortable sensations such as tingling. Sometimes these neuropathies occur in the most distal limbs first, such as the feet. And sometimes these neuropathies are called non-length dependent, which means that they can begin on any area of the body potentially, or on multiple areas of the body at once. As we mentioned before, the symptoms often involve pain or tingling or other uncomfortable sensations. And these type of sensations tend to occur more frequently in small fiber neuropathy rather than numbness or an absence of sensation. And again, because the small diameter nerve fibers do not connect to muscles, weakness will not be a symptom in this type of neuropathy. One thing that was interesting to note from a recent publication was that sometimes small fiber neuropathy can cause muscle cramps. And recently, in an evaluation of 12 consecutive patients with muscle cramps, but without any other neuropathic complaints such as pain or tingling, 60% of these patients were found to have small fiber neuropathy as diagnosed with skin biopsy. And we'll discuss the skin biopsy and other diagnostic techniques in just a little bit. As I mentioned before, the small diameter nerve fibers also provide innervation to different organs in the body, and they subserve certain autonomic type of functions. These are automatic control of different biological functions in different organ systems. And oftentimes when there's something that involves on a broad scale the small diameter nerve fibers, this can result in a component of autonomic symptoms due to an autonomic neuropathy. Some, but not all, small fiber neuropathy patients may also develop symptoms of autonomic neuropathy. And again, this is because certain peripheral autonomic nerves control vital body functions, which we do not consciously think about, and these can include things such as blood pressure, heart rate, digestion, different activities of the pupil in response to certain light levels or certain situations that we're in, sexual function, and bowel and bladder function. So along these same lines, some patients who have neuropathy that involves the small diameter nerve fibers can have dysfunction and symptoms in these areas that could result in things such as constipation or diarrhea, blood pressure changes with changes in position, which can cause dizziness, for example, with standing, difficulty with urination, incomplete bladder emptying, and abnormalities in sweating, as well as other symptoms. On physical examination, overall small fiber neuropathy tends to have many fewer findings compared to other types of neuropathy. However, clinical signs on physical examination of a person with small fiber neuropathy can potentially include reduced temperature or pain sensation, such as might be tested with a pin or other sharp object, reduced light touch sensation, increased sensitivity to touch, which is known as hyperesthesia, or painful sensation to a light touch, which is known as allodynia. However, as mentioned before, in many cases, the sensory examination may also be normal. And as you can imagine, this can potentially make the diagnosis of this condition more difficult. So when the clinical suspicion for possible small fiber neuropathy arises, there are certain types of tests which are specifically useful for diagnosing small fiber neuropathy. As you may remember, neuropathy involving large diameter nerves is detectable with nerve conduction studies, but in cases where there is neuropathy that only involves the small diameter nerve fibers, this type of neuropathy is not detectable using nerve conduction studies. There are other tests available for this, which we are about to discuss. But first, I also wanted to mention that testing for small fiber neuropathy is important for several reasons. First, of course, for some of these patients, as you can imagine, with symptoms, but with possibly no abnormalities on their physical exam, validating objectively the diagnosis of small fiber neuropathy can lead to a significant amount of psychological relief, knowing that there is an actual cause for the patient's distress. Also, of course, an objective diagnosis facilitates a search for the cause for this patient's small fiber neuropathy, as well as subsequently looking for treatment. So, again, the tests for small fiber neuropathy include quantitative sensory testing, and this involves an automated standardized system that essentially quantifies thresholds across several sensory modalities. So there are various instruments, for example, that can very, very sensitively measure exactly when a patient is able to detect certain subtle temperatures or certain subtle changes in textures, and this allows for a more precise and sensitive means of detecting abnormalities in sensation compared with what you might normally experience in a doctor's office. In addition, skin punch biopsies are a very useful tool for diagnosing small fiber neuropathy. Here, the density of a small diameter nerve fibers are measured in a small, approximately 3 millimeter sample of epidermal tissue. And in small fiber neuropathy, there is a reduced number of nerve fibers. And the measurement that is referred to is the reduced epidermal nerve fiber density. Once the diagnosis of small fiber neuropathy is secured, then one begins to think about potential causes. Many causes of small fiber neuropathy are similar to those of large fiber neuropathy. For example, small fiber sensory neuropathy is a major manifestation of type 1 and, for that matter, type 2 diabetes. And in some studies, it has been shown to be more prevalent than large fiber neuropathy. One reason to search for the cause of the small fiber neuropathy, of course, is that if the cause of neuropathy is found, this can improve the chances of treating the neuropathy. However, unfortunately, in approximately half of cases, no cause for small fiber neuropathy is found, despite the best efforts of neuropathy specialists. Ongoing research continues to search for additional causes, and on an ongoing basis, we are discovering new answers for some of the patients whose neuropathy was previously considered idiopathic, which means that no cause was previously found. This can also reinforce the utility of having follow-ups periodically if your neuropathy is idiopathic, because with further developments in research, additional possible causes for neuropathy are continually being discovered. At this point, a sampling of potential causes of small fiber neuropathy include various metabolic conditions such as diabetes or even borderline diabetes, toxic effects including alcohol abuse, heavy metals, and certain medications, deficiencies or excesses of certain vitamins, certain infections, autoimmune conditions, hematologic conditions, hereditary neuropathies, certain other hereditary conditions including Fabry's disease, familial amyloidosis, and a more recently uncovered cause known as voltage-gated sodium channel gene mutations. I'd like to discuss a little bit more about the relationship between small fiber neuropathy and sodium channel mutations. As I mentioned previously, approximately 50% of patients with small fiber neuropathy have what's known as idiopathic neuropathy, meaning no cause for the neuropathy was found after an initial workup. In one study of patients with idiopathic small fiber neuropathy, 30% of these patients were found to have an SCN9A gene mutation. This mutation produces an abnormal increased function in a nerve sodium channel. And this type of sodium channel happens to be more specific to small diameter peripheral nerves. Therefore, it's important to note that this type of mutation may not be able to account for an equally high percentage of idiopathic large diameter neuropathy cases. One additional point related to the sodium channel mutations and the neuropathy pain with some of these, for some of these patients, is that the treatment of pain symptoms for these patients may be best achieved by using neuropathic pain medications that decrease sodium channel activity, such as gabapentin or carbamazepine. Ways to evaluate for potential causes of small fiber neuropathy include a careful, detailed history, including evaluation for possible exposures to certain medications or toxins, a family history of certain conditions, risk factors for certain conditions, and a detailed medical history. Looking for certain physical examination features suggestive of other potential contributory causes is also important. Laboratory evaluation is important, and it may include genetic testing, such as for the gene for the sodium channel mutations that we previously discussed. In addition, some providers may begin an evaluation of an individual patient by looking for the most common causes for small fiber neuropathy, and then depending on the results of initial testing, they may broaden their search for more obscure or detailed tests. In terms of treatment for small fiber neuropathy, if a reversible or treatable underlying cause is identified, then this should be addressed. For example, if blood sugar control is achieved and maintained in a patient who has diabetes or borderline diabetes, or if a vitamin deficiency is corrected in a patient who has a deficiency in a certain vitamin, then over time the neuropathy may improve. This is difficult to precisely predict as each patient's clinical situation and course is different. However, it is known that controlling an underlying cause for a patient's neuropathy can prevent the progression of the neuropathy, and over time, spontaneous remission of the neuropathy is possible. Another interesting development that has recently been reported is that in certain types of autoimmune-related small fiber neuropathies, treatment with IV immunoglobulin may also be effective. Another final point that I would like to bring up is the interesting possible relationship between small fiber neuropathy and fibromyalgia. As we may know, fibromyalgia is a recently described constellation of symptoms for which no unifying underlying cause has been found. Several recent studies have shown that a significant proportion of patients with fibromyalgia have reduced epidermal nerve fiber density on punch skin biopsies. Therefore, this suggests that at least for some patients who have been diagnosed with fibromyalgia, an underlying diagnosis of small fiber neuropathy may actually explain their symptoms or some of their symptoms. Additional research is ongoing, but the cause for other painful conditions or syndromes may in the end be also related to small fiber neuropathy. Thank you very much for your time, and I hope that this was informative. I will now turn over the presentation to Dr. Corey Hunter, a pain management specialist at Ainsworth Institute of Pain Management. Dr. Hunter also serves as a member of the Neuropathy Association's Neuropathic Pain Management Medical Advisory Council.
All right, thank you, Dr. Patterson. Again, my name is Dr. Corey Hunter. I'm an interventional pain management doctor, so I'm going to be picking up here on some of the treatment that we have for small fiber neuropathy. So as was mentioned, small fiber neuropathy is frequently associated with what we call neuropathic pain. There are basically a plethora of symptoms that can be associated with. A lot of them were already discussed: the numbness, paresthesias, which is a fancy word for basically tingling sensation. There are a variety of medications used to treat neuropathy, but basically there's not a lot of evidence, or there's limited evidence for which ones are going to be good for small fiber neuropathy. Again, there are consensus guidelines for what we use to treat neuropathic pain, but a lot of that's still kind of in limbo as what we're going to use for small fiber neuropathy. So how can how can clinicians partner with patients to select the best pain management treatments for them? Well, there's really, just to read these first and then kind of go over them. Efficacy are basically, evidence of safety, efficacy in other neuropathic conditions, tolerability, cost, comorbid conditions, and drug interactions. Now, that's basically what it comes down to, and a lot of what we do with neuropathic pain is can you tolerate the medication? The medications typically will go along with a lot of side effects, which can be dizziness, water retention, somnolence. A lot of these fall into the classes of anti-epileptic medications and antidepressants, and these carry their own side effects with it. So what we kind of teach is you go up on the medication until either the pain goes away or the side effects become too much. So there's really a lot of that included in there. The other one I wanted to highlight is cost. One of the older medications is gabapentin, which is very cheap, but you have to kind of go up and up and up on it. One of the newer medications, Lyrica, people seem to tolerate much better. However, because of its cost, a lot of insurance companies shy away from paying for it. And one of the other ones, drug-drug interactions, basically a lot of patients tend to be on sometimes other medications with the antidepressant kind of tag with it, and these medications don't usually go well with other and within the same class. So there's a lot to take into account when trying to choose the best paradigm for neuropathic pain, let alone small fiber neuropathy. And another thing that is really important is partnering with a multidisciplinary group. This tends to be more prominent at university hospitals, where they'll kind of you'll have a pain management doctor, you'll have a neurologist, a physical therapist, and everybody will kind of team up together to come up with the best approach. And in neuropathic pain, this is of a very, very big up-and-coming thing to have the multidisciplinary team, but particularly in something as emerging as small fiber neuropathy, it's really important to have a lot of brains in the room to kind of come up with what would be the best course of action. And as you just saw with the pain medications alone, it can be a very, very difficult course. So having a lot of people kind of weighing in on this for the treatments is really the best option. So on the next slide, treating the underlying cause is really going to be one of the easiest things to do, as Dr. Patterson had brought up. A lot of times and as you can see in the next bullet, a lot of times we don't know what the actual cause is, so it gets that quote-unquote idiopathic diagnosis, or we don't know what it is. In the cases where we do know what it is, you can very easily treat it. You can take the bullet out of the bullet wound and watch it heal. So with small fiber neuropathy, if you can find the underlying cause, to get rid of it is going to be the best things. In diabetes, if you can improve a person's blood sugars, some of the small fiber neuropathy will improve. So that should be pretty easy. Find the reversible cause and try to treat it. In the cases where it is idiopathic, some of these patients will get better on its own, but a lot of times it won't. So just really kind of making sure that you don't too quickly give it the quote-unquote idiopathic diagnosis is really of the utmost importance. Doing a comprehensive evaluation and seeing if there is an actual reversible cause and keep digging at it, but also reassuring the patient that there is a possibility that you may not get to the bottom of it, so for them not to always kind of keep their hopes too high. Next, evaluating and treating the autonomic symptoms. Now, this was mentioned in one of the previous slides. These are very vague symptoms, the sweating, immobility of the gut, orthostatic hypotension, which is a fancy way of saying you get dizzy when you stand up because your blood pressure drops. These are going to kind of be vague, but in the constellation of symptoms, having this along with a kind of neuropathy or having, the excessive sweating and the dizziness with standing up with something like numbness or pins and needles or a tingling sensation, that should be taken into account. And kind of, evaluating and treating the comorbid symptoms. So, and this can also extend into the medications as well, but more specifically, patients will have anxiety and depression, and this is, related to what patients are feeling. They're going to be having these, like I said, these constellation of symptoms, and sometimes, the doctors don't exactly help. They can kind of exacerbate the matter by not knowing what's going on or not answering the patient's questions correctly. So they can get anxiety from the disease and not necessarily just from the disease, but they can get it from just having the disease itself. They can get anxiety and depression because they don't know what's going on. Okay, and the next slide. So this is a pretty busy slide, but to kind of go over it, with most things we do in pain management, we have basically the first and second line and third line treatments for pain, because even when there is the consensus guidelines, you may not be treated by the first medication or the second medication. You have to go along to even third, fourth, or fifth line medications. But to go here, the first one, gabapentin, that's also known as Neurontin. Now there are newer versions of it, once daily. Pregabalin is also known as Lyrica. So these are some medications that people might have heard of. So these are basically what is recommended in the textbooks to start with. You start with these. You start with something like gabapentin. You titrate up. You start with things like Lyrica, and you titrate up. And as I said before in 2 slides ago, that if you kind of want to go up until the either the side effects become too much or the pain goes away. Topical lidocaine, another one of the more popular ones, is the lidoderm patches. So after you kind of exhaust these in the first line, then you go to the second line, which includes your antidepressants, things like venlafaxine, nortriptyline, amitriptyline. Those are both in the tricyclic antidepressant group, which we don't use as much for depression anymore. We use them more for the treatment of pain, not just small fiber neuropathy or neuropathic pain. And then third line, tapentadol and tramadol. These are more pain medications that, as a side effect, they happen to help with some kind of neuropathic pain. As you will note here, that you don't see anything like Percocet or oxycodone or any of the more traditional morphine or opiate-related pain relievers. These are not considered to be first, second, or third line treatments, but people often find that they're prescribed it by their primary care doctor, and it's not because it's the best for it. It's just that sometimes physicians don't actually pay attention to what the consensus guidelines are for these types of neuropathies. So it's as advantageous to patients to also know before they go into their doctor what would be the best thing for them, or at least to have an idea of what's out there that's considered to be the best thing for them. And on the next slide, non-pharmacologic treatments. So some of these things your physician may comment on, some they may not want to comment on. Typically, like things like dietary supplements, as physicians, we're not technically allowed to comment on if they're not considered FDA-approved treatments for it. Things like echinacea, we're not typically allowed to comment on, but there's a plethora of information on the internet. Things like acupuncture, biofeedback, yoga, these basically can run the gamut of different ways to treat the pain. It doesn't treat necessarily the cause or the source, but it can help with the pain. Things like biofeedback would tie into a type of physical therapy, and it can help people kind of manage their pain a little bit better. And with physical therapy and with the last one, cold, warm soaks, there are different types of basically ways to manage the temperature in the extremity that's affected, whether it be the foot or the hand, where you can kind of offer like contrast baths where a little bit of hot, a little cold, and it can kind of help manage the pain and mitigate the sensation of the numbness and the pins and needles and the tingling. So it's very critical, as I mentioned before in the previous slide, to also come to your doctor with questions. Well, what do you think about this before you try me on something like that? Or I heard before you give me Percocet, I heard that's not maybe necessarily the best thing for me. What about this medication. There's nothing wrong with coming to your doctor with a lot of questions, because when you walk out, you'll feel a lot better about the treatment that's being offered. So on the next slide, in interventional pain management, this is what we'll typically try after the non-pharmacologic treatments, after the medications, after this has gone on for a while. We'll try different types of things to kind of treat the source of the person's pain. Again, not actually causing a cure or creating any kind of cure or getting rid of the reversible cause. This is something that we can do as part of the multidisciplinary approach to help treat the pain while, say, another physician is doing their job. Everybody's kind of putting their hand in the cookie jar trying to help a little bit. One of the things is infusion therapy. This is a very non-invasive technique. One of the medications we use is ketamine. This is a much older medication that fell out of favor over the last couple of decades, which is now becoming popular again to treat neuropathic pain. It used to be used in the anesthesia realm to induce patients before they go for surgery. Lidocaine is basically the cousin of Novocaine, and we can infuse both of these intravenously to kind of mitigate some of the symptoms of the pain. It can help calm down these upset nerves. It can help relieve some of the painful symptoms. The ketamine is usually done initially in the hospital. Requires a couple days of overnight stay in a telemetry unit where you're hooked up to monitors to monitor your heart, and you'll come in for booster therapy in your physician's or doctor's office. Lidocaine is one that's done pretty much predominantly as an outpatient. They're both not the most common things that are done, but they can be very effective when done correctly. Regional nerve blocks, if someone has pain in, say, the certain distribution of a certain nerve or a certain area, you can block the nerves under ultrasound and very easily kind of calm down some of the symptoms. Again, this doesn't treat the source, but it can treat the pain more directly. Sympathetic blocks. This is basically, when we were mentioning before, the autonomic symptoms, the subconscious symptoms, the nausea, the gastrointestinal or the GU issues in the body that are related to this. Sympathetic nervous system is what contributes to those areas. So we can kind of block those areas under X-ray to, again, mitigate the symptoms. So the stellate ganglion is, for lack of a better word, think of it as like a grand central station for where subconscious sensation would go through in the upper extremities. So we can, under X-ray, deposit a little bit of lidocaine on that ganglion and disrupt some of the pain signals, so it's kind of a hard restart for the pain in that area. The lumbar sympathetic chain would be the equal of the stellate ganglion, but for the lower extremities. So we just deposit a little bit of lidocaine there, cause that sensation to kind of drop out, and then once it restarts, you turn the computer back on, hopefully some of those symptoms will be less, and we can repeat it. Spinal cord stimulator is one that's a little bit more one of my favorites. The idea is that you will cancel out one sensation by introducing another. So with spinal cord stimulators, you create an electrical signal in a certain part of the spinal cord that is associated with vibration, sense, and light touch. So you create a massage or a pleasant tingling sensation as opposed to a painful one. And what this will do is your body can only process so much sensation into a particular area, so the pain will get canceled out. And in turn, it'll create a pleasant sensation. So this is something else that we do, which is very, very effective for treating a lot of types of pain, and particularly certain neuropathies. And the last one is intrathecal pumps. This is seen by some pain management doctors previously as more of like a dead end once you've tried everything else. But in many patients, this can be a lifesaver. What it is think of it as like an internalized IV. You have a small little pump the size of a hockey puck, which you basically put under the skin, in a small catheter that goes into the nervous system area, more specifically the spinal cord, or spinal cord corresponding to one particular part of the body, and you infuse micro amounts of medication. So rather than taking pills and having it go to the whole body, you can deposit pain medication or certain types of anti-neuropathic pain medications to one particular part of the spinal cord that corresponds to the lower half of your body, let's say, and basically treat the pain more directly. But this is a little bit more than some doctors are willing to handle, so it's not done all the time. And lastly, clinical research. Clinical research is the most important thing for any field in medicine, particularly what we do in pain management, because it's such an emerging field now. Some of the studies that are listed here are, some of the ones that are a little bit more prominent. The first one is for a medication milnacipran, which is also known as Savella. It's a SNRI medication. So this is now this has been used a lot for fibromyalgia. Of the 3 medications that's there, so this is now being investigated for idiopathic neuropathic pain. Another medication, the second one there, is also lacosamide, is anti-epileptic medication, also known as Vimpat. So this is also being studied now for small fiber neuropathy. Thermomentax. This is basically a medication that consists of a lot of different B vitamins. I believe it's B9 is in there, a few others. So this is being investigated. And the last one, gabapentin for Fabry disease. Again, just to review it, Fabry is a lysosomal disease, or basically it's a disease where it's a dysfunction in the metabolism of sphingolipids. And that's a really fancy way of just saying you can't process fat correctly. And fat is one of the key ingredients for creating myelin, which, as Dr. Patterson mentioned in her earlier slides, is what's implicated in what we call either a large fiber or a small fiber. So again, these are just different medications that we're kind of looking into right now to see if we can better treat neuropathies, and more specifically small fiber neuropathy. So thank you very much for your attention, and now we're going to open up the forum for questions.